Jorge Sánchez, quien es investigador principal del Centro de Excelencia y coordinador de la unidad de ensayos clínicos que desarrollamos conjuntamente con el Instituto de Medicina Tropical de la Universidad Nacional Mayor de San Marcos. Asimismo, el doctor Sánchez se encargará de la conducción de esta sesión. Doctor Sánchez, tiene la palabra.
Muchas gracias, doctora Alarcón. Bueno, es un gran placer para mí presentarles al doctor Frederick Altice, gran amigo, colega y colaborador con el Perú desde hace 10 años y que ha dado una muy fructífera colaboración con más de 14 publicaciones en estos últimos 10 años. El doctor Altice es el profesor principal de la Universidad de Yale y es certificado en enfermedades infecciosas y en el abuso de alcohol. El doctor Altice trabaja en Europa del Este y en Centroáfrica en diferentes enfermedades como son VIH, tuberculosis, hepatitis y en investigación del abuso de alcohol. El doctor Altice el día de hoy nos va a dar una conferencia en Ciencias de la Implementación en la práctica, ampliando la prevención del VIH en Ucrania. Adelante, doctor Altice. Welcome.
Thank you, Jorge. Thank you, Dr. Alarcón, for inviting me to present on this topic. I thought it would be rather interesting to really go over a sort of an area of emerging science called implementation science. And I'm going to show you some actual data from Ukraine that we've been working on for the last bit. And as I move forward, I just want to make sure that I provide my disclosures and funding from a number of different agencies, as well as to acknowledge, as in all research, it takes a village. I have colleagues from Ukraine, the US, and from England with whom I work on this particular work. And so I think that in order to really set the stage, and I suspect that not many of you are as familiar with implementation science, but it's different than clinical trials. It's scientific study of methods and strategies that facilitate the uptake of evidence-based practices and research into regular use by practitioners and policymakers. And I'll spend a little bit of time at the beginning trying to sort of explain what that means. And it seeks to systematically close the gap between what we know and what we do. This is often known as the no-do gap, and to identify those barriers that slow or halt the uptake of these health interventions and practices. So I think the real question in public health is, how do we get what works to the people who need it? Many of you all are probably involved in clinical trials, and you have protocols and things that sort of restrict what is done but may not apply in the real world once you get out there. But it's how to do this with greater speed, fidelity, efficiency, quality, and adequate scale up. Let me see if I can get this to work here. So the question would be, is the no-do gap is kind of looking at where we were yesterday, like what did we know? What do we know today? Hopefully we know more. And then what we hopefully will know tomorrow as new knowledge emerges. And that is really what we're doing right now. And this is often very different between, what we actually can do. So this gap is the sort of the difference between the knowledge, what we know, and what we're actually doing. And as we gain more knowledge and we get more experience and practice with it, we become more efficient with the work that we're doing. And to sort of put implementation science into the sort of the perspective of what I call anything from preclinical research, sometimes referred to as phase 1 studies. Many of you all are probably involved in efficacy study, these randomized controlled trials. And then, of course, we begin to move into effectiveness studies, which are sometimes called pragmatic trials, what sort of works in the real world whenever you don't have a very controlled setting, to even beyond that into implementation research. The kinds of designs that we use are very different for these implementation trials, and I'll spend a lot of time on that. And that is to really move it into having a public health impact. And the reason why this is important to have implementation science is that in general, once you begin a study, let's say to work on PrEP as an example, and take it through the trials, it often takes 17 years from the time that you start the research to actually getting a wide-scale adoption. And this really only occurs for the 14% of those who actually get through. So you can accelerate that time so that you can, instead of taking 17 years, you might be able to do it with effective implementation to as early as 3 years. So it shortens that treatment gap as well. And we all know that we've seen a ton of different clinical trials that show great efficacy, but in reality, they're not really out there. And I think that, you know, you can sort of just look at PrEP as an example. Peru was one of the original participants in the IPREC study, and there's very few patients who are actually on it right now. So how do you sort of, you know, alter that gap is the question. And part of the way that this is done, you know, really goes back, you know, several decades, 60 years or so, to Rogers' diffusion of innovation. And, you know, if you sort of think about where things are, you know, there are those people who were innovators. And so you might want to think about like the iPhone, Steve Jobs sort of, really creating this thing. And then there were people who were the early adopters, which only accounts for about 14%. And these are the people who get it and they've tried to figure out a way to do it, and they do it early on. And then, of course, you have the early majority and the late majority, which really accounts for about 70%. And these are the people who are what I call hesitant. They're not quite ready to take this on. This is kind of where, let's say, Peru is with PrEP in terms of sort of moving the field, but that really accounts for much of the scale up. And then, of course, you've got the laggards who are just never going to adopt it or to implement it, and that accounts for the last 16%. And what ends up happening with implementation is as you improve the quality of the way that the delivery of your evidence-based practice is, what ends up happening is people begin to buy into it. They become more efficient at it. They think about how to do it easily and with more flexibility. And then you can actually optimize your scale up. And just to sort of, you can't really read the details of this, but I can sort of walk you through this is, you know, where we are today with sort of one pill once a day with just a handful of regimens that are really quite effective and safe. You know, we've spent the last 40 years with an HIV response, and some of it still remains very slow. We've got 90-90 or 95-95-95 targets, and there's almost no countries around the world that have really achieved that. So sort of think about, you know, where we are, but there have become some efficiencies and flexibilities in terms of single treatment regimens, medications that have fewer side effects, being able to sort of have in many places like in Africa, having nurses and outreach workers actually do the treatment because the medications have gotten so safe. And so this task shifting, these are all things that have happened along the AIDS response to sort of facilitate implementation, if you will. Now, there's a number of key attributes that we sort of think about with regard to things that might affect the extent to which an intervention is innovative. And that is, what is its relative advantage? So I'll use the word of PrEP. You know, for instance, is long-acting PrEP more advantageous? Is it better than what's out there? Compatibility. Does the innovation fit with the intended audience? So in other words, if you have a group of people who are afraid of needles, they might not want an injectable, but you're trying to foist it on them. How complex is it? You know, how easy is it? Does it require that people have to have a lot of constraints or demands on their time, or demands and constraints on the clinician? Or is it expensive? Its trialability, that is, can the innovation be tried before you have to make a decision to adopt it? And so there's some implementation trials that are called hybrid trials, which might be helpful in sort of doing some of that. And then, are the results of the innovation observable and easy to measure? And so the more complex that you make this, that's why the HIV treatment cascade is moved from 6 elements down to 3 because you can easily measure how many people are diagnosed, how many people are on antiretroviral therapy. You can use pharmacy data for that. And then what are the viral suppression levels? And if you have a national database, you can look at that percentage. And so, can you observe that you're actually sort of making a difference in that group? So what we sort of think about in terms of what I call the diffusion, dissemination, and implementation cascade is diffusion means that you have a clinical trial and it works. So it has become an evidence-based practice. Think once again of PrEP. The diffusion just says, let's watch it happen. Well, we know that not much has happened, at least in that regard here. Dissemination is where you begin to disseminate it across multiple different settings within the country. So that's sort of helping it happen. And one of the ways that might happen is, let's say the Peruvian government might decide to purchase that. So that becomes a dissemination exercise. And implementation is actually making it happen. And that usually is done with an element of some kind of facilitation. So it's moving the evidence across the spectrum. Now, it's really important to do a couple of things up front when you're implementing. So you have to name a strategy that makes sense to you. So PrEP, for example, would make sense. I'm going to change out some of this terminology when we get to Ukraine. And then we're going to define it. Now, I see that there's a hand raised. Do we want to stop and take questions during that? Would that be a useful way to do that? Jorge, I don't know how you'd like to run this, but I'm happy to take questions.
Por favor,
el que tenga
sería
preguntas,
conveniente
por
que
favor.
las preguntas se realizaran al final de la presentación de la conferencia, doctor Altice.
Okay, right. I just see that people are raising their hands. So
Yeah.
it's really important to specify, the implementation strategy. So you want to name it. So if it's PrEP, I'm going to be talking about methadone or treatment for opioid use disorder. So it needs to be something that people recognize. You need to define the implementation strategy and what you're going to be doing. So specifically around that. And there needs to be some specificity because what you might do in Peru could be very different than what you might ultimately end up doing in sub-Saharan Africa or in Eastern Europe, et cetera. So you have to know who the actors are, who you're actually, that is, who's going to be doing the work, what they're going to be doing, what is going to be happening in terms of timing, the dose of the implementation, in other words, how much intervention has to happen. And you need to be able to measure what that outcome is going to be so that you know whether your implementation is effective or not. Now, the other thing about clinical trials, or I should say trials for implementation studies, is that they're very different than what we sort of think about. Of course, the cluster randomized controlled trial is an implementation design. It looks very similar in some ways to other standard clinical trials. And so that will look the most familiar. I'm not going to spend a lot of time on these other than to point them out. The other ones that are in the more controlled design methods happen to be stepped wedge, where you take a look at what happens before you start implementation and then what happens afterwards in a timely fashion. There are hybrid trials, which either focus more on efficacy or more on the actual process outcomes. And then there's the Presses 2 designs, which actually help you decide what is the right way to do the trial to answer the question that you want. And there's a whole website devoted to this. A lot of implementation science does involve some quasi-experimental designs. They're not quite as strong. There are the interrupted time series, which we've done a fair amount of, some regression discontinuity, regression point displacement, and linear growth modeling. These are all ways to sort of think about how things move over time and how different activities within your implementation influence the, let's say, the scale up or the increase in time. And then the other thing that is really sort of key in implementation science is really understanding a framework or some models that you might be sort of using in doing your work. And a lot of it will depend on the question that you're doing, but there's actually over 100, I think there's about 108 different frameworks that are being used out there. Some of them are classical theories. Most of the sort of the research falls more into the determinant frameworks. Implementation theories might be like the Rogers diffusion of implementation. And then there may be some evaluation frameworks that are really quite common that we might use in order to sort of make sure that we have the right explanatory variables to improve our outcome. There's a handful of ones that are what I call the Mercedes or the Cadillac versions that you can see listed in the top set of bullets in here. I'm going to at least show you one or two of them just to sort of think about how this works. And then there are probably, if you look across any of them, there are some key elements. One of them is, what is the innovation about your evidence-based practice? In other words, is it the right evidence-based practice for the right setting and the people who are going to be delivering it? In other words, you can't have a highly technical evidence-based practice that would be implemented in a place that doesn't have the technology, for example. Are there unique factors, let's say laws, policies, regulations, funding, that would differ from context to context? So the context really matters. And then how do the key players interact? The client, the provider, the clinic itself, the healthcare system, and the government policies. And we all have recently seen that even across Peru with, let's say, scale up of antiretroviral therapy, it differs quite dramatically by region. And some of these factors are some of the explanatory reasons for why it doesn't work. And it may require some changes in the way that the implementation occurs. And then, of course, since facilitation, that is sort of making it happen, is an important component of implementation science, who's facilitating? Are they using the right interactive method? And is that method, adopted towards context? I'm going to go over one framework, the one that I'm going to be talking about tonight. This is the IPARIS framework. And it's really very simple. It's got three major elements. So what is the evidence? Does your intervention work? That is it effective? Is there experience with it, both from the patients and the providers? And what's the sort of local information? That is, how do people feel about that? Then there's the context, which is how are things organized? What is the structure and the reporting system? And what is the leadership and that may actually influence the adoption and the scale up? What is the culture around treatment? And is there a way to have an evaluation plan that is meaningful? And then, of course, there is, sort of facilitation. And the other term I use for this is coaching. Is the coaching appropriate? Is the person who's coaching it doing it the right way? And are they doing it to the right audience? So in other words, if you're coaching to physicians, but you're expecting, let's say, nurses or outreach workers to do the work, then that would maybe perhaps be a mismatch between the coaching that is expected. What is the purpose of the coaching? And then what are the skills that are needed? All of which can lead to successful implementation. So let me take you to Ukraine, because in every story of implementation, there's always a starting point. I first went to Ukraine in 2004. What happened in 2004 and very much sort of explains where we are in 2022 with regard to the war that's going on there. It is essentially the people of Ukraine standing up for their rights and wanting to make a difference. And I was there, and I have been working there ever since the Orange Revolution in 2014. But the question is that, what do you need to do in this region and why? So if you take a look across the entire globe, there has been a 50% reduction in deaths related to HIV, and there's been a reduction of about 10% in incidents. So the world picture looks pretty good as it relates to HIV, and you can see that Peru on this map is solidly in the green. But in this particular region, you see that the deaths are increasing by about 25%, and new cases are increasing by nearly 60%. And all of this is in the setting of suboptimal HIV prevention and treatment. and because the evidence-based practices are not being sort of rolled out. And what's really unique about this particular region of the world is the HIV epidemic is driven primarily by people who inject drugs, which looks very different than the rest of the world, where it is mostly a sexual transmission issue. So what are the evidence-based strategies for HIV prevention? There's in people who inject drugs. There's essentially four that we have. There's treatment with medications for opioid use disorder, sometimes called OST or OAT. And the recommended targets is at least 20% and preferably 40%. Syringe services programs is another one, but it has to be implemented so that on average, each person gets greater than 200 sterile syringes per year. Treatment as prevention is important. That is getting people onto antiretroviral therapy, but among people who inject drugs, they're seldom likely to get it because either the doctors won't prescribe it or they're not engaged in care. And then, of course, there are PrEP trials. The Bangkok tenofovir PrEP trial showed that HIV incidence was decreased by 49%. Looks very similar to the IPREC study. So we do have some benefits, but these are all interventions that are not commonly there. But what is going to be most important to Ukraine? And this is the idea that OST or medications for opioid use disorder and treatment as prevention are highly interlinked, because when people get on to methadone or buprenorphine, they are more likely to get antiretroviral therapy and take it. So one of the things in terms of thinking about your HIV prevention is sort of looking at your two cascades. In Ukraine, there is a huge treatment prevention gap that is present here. There's about 240,000 people with HIV. And then there's a big treatment and prevention gap for people who inject drugs. There's about 336,000 individuals. And if you take a look at the coverage, so for treatment as prevention to work, you need some viral suppression. If you try to get to the 73% that's required to be virally suppressed, that's a 35% gap, or you could say it's a 62% gap in order to get complete coverage. And in the case of opioid substitution therapy or opioid agonist therapy, there's a 14% gap in terms of your treatment prevention. And this means that you've got room to go. And these create opportunities and they create targets for measuring your outcome. And so how effective is the treatment that we have that's available here? This is a mathematical modeling study that was done, and we've sort of repeated some of this more recently. But if you take a look at what's going to work, and these are methadone and antiretroviral therapy, two of these evidence-based practices, and we look at high, medium, and low coverage for these, you can see that on the left for methadone, high methadone coverage will give you the most sort of HIV prevention benefits relative to antiretroviral therapy. And of course, on the far right, if you combine them, of course, you can really reduce the most infections. In fact, it's synergistic at that particular time point. But what's really important when you apply a cost effectiveness model to this, because methadone on average costs 6 cents per day, and we know what the cost is for antiretroviral therapy. Methadone is 4 times cheaper per every infection averted relative to antiretroviral therapy. Now, that doesn't mean that you should eliminate and choose only one, but you can see that when you combine it, the cost effectiveness is in the middle range of about $1,000 per infection averted, which is relatively cheap in the scheme of things. These are data from our group in order to establish that HIV treatment as prevention is effective. And we took a look at over 540 patients with HIV. And we took a look at the entire HIV cascade. And you can see that for those patients who were on methadone or buprenorphine, or OAT as we call it, at every single step of the cascade, you have this synergy. That means that you are more likely to be engaged along the HIV care continuum, which makes OAT a very important strategy for coming in. So why use implementation science? In this case, well, one is you need a sustainable plan. We're using a method that creates a local expertise, and we're using a NIATEX treatment model, which I'll talk a little bit about. And one of the things about implementation science is, let's say you get it really good, you really become effective at sort of scaling up methadone. Those strategies are applicable to almost any other disease state. You can just say PrEP, you can say ART, you can say TB treatment. All of the skills that are used can be applied across disciplines. And what it does is it provides a model for the delivery of better care. That is, you have better patient outcomes. And the idea is that you do better care with less or the same amount of money so that it can be sustained. If you start to add on costs as you're doing these implementations, like by, let's say, getting a grant and providing peer models, those extra costs may not be sustainable. And we certainly know from Peru that the TB program got into a little bit of trouble when Partners of Health pulled out with their external funding for a resource that wasn't necessarily able to be replaced. Now, part of what is important in these implementation plans are going to be understanding the context all the way from the individual to the policies. So one has to work within the geopolitical realm of where you're doing the work and sort of understanding that. And one of the things that we did up front is we sort of explored what were these barriers and what were some of the potential facilitators that could be used across this. We did some qualitative research. We did a fair amount to sort of understand what they are. And this particular model that we've described here sort of lists those factors that got in the way of scaling up methadone throughout the country. And then our conceptual model for this, because it's really about getting more people on treatment, is we sort of recognize that we've got, a large number of people who inject drugs. On average, about 20 to 25% of people who inject drugs have HIV. So it's a 1 in 5 or 1 in 4 sort of proportion that you also get the simultaneous benefit of getting people onto antiretroviral therapy. And you may have a certain census of people who are on treatment. Let's just say right now we know that we're at about 6% coverage. And we recognize that that census can actually change. And that's your whole goal, is you want to go from, let's say, 5%, and you can choose a number, let's say get it to 10% or 20%. And that, whenever you're doing implementation science, becomes your expectation, so that you can say in 1 year with your implementation, we want to go from 5% to 10% coverage or something like that. And what's really important about this is that there are only 2 inputs that will actually get that to happen. One of them is going to be the number of new patients who are entering onto an evidence-based practice like methadone, which is extremely effective for HIV prevention, both primary and secondary HIV prevention, by the way. And it's going to be the dropout. That is, those people who drop out of therapy. Now, remember, when you're doing this sort of work, you can modify this and you can say PrEP, you can say antiretroviral therapy, you can say patients who have controlled diabetes. You can use any of the evidence-based practices across a number of disease states whenever you're doing the implementation science. But it's the science of driving the factors that really makes a difference. And when you improve the census, part of the way that that happens, and through Rogers' diffusion of innovation, is by improving the quality and the way that the service is delivered. More people will come in and remain in treatment through that quality effect. So when we think about, let's say, people who inject drugs, we have taken, at least from our perspective, what I call a touch point perspective. That is, where do people who inject drugs touch the systems of care? And this is a pyramid going all the way from prison, jails, probation, primary care, pharmacies, addiction treatment, harm reduction programs. And what we've done is we've got a number of grants across all of these, but we're going to focus specifically on the addiction treatment clinics within the community for today's presentation. And I'm just going to touch a little bit on some of these other things because we've got large cluster randomized trials to answer some of these questions, but I won't have time to get to those. So what we've done is we're using something called NIATEX. NIATEX is a treatment improvement implementation strategy. And it has a number of tools that we use, but it sort of works from the idea that you set an expectation. That is, we will go from 1,000 to 2,000 patients who will be on treatment. So in other words, you need some numeracy about that, because if people just are told we need to increase the numbers, increasing it by 1, it might seem like the same thing as increasing by 1,000. We give them ongoing support, that is coaching. And then one of the things that we have increasingly done, at least in this setting, is that we have created rewards. And those have become what we call challenges. And what we did is, there's a part of what I call learn as you go. So we have a couple of phases with this work. We made a few mistakes. We had the wrong connection between our coaches and the people who were our targets. We were mostly working with harm reduction. We changed that to somebody who had a leadership position, that is the head doctor in each of the regions of the country. We modified the stakeholders and we used learning collaboratives. That is, people would actually talk about what they were doing, how they were doing it, and then they would show the measured outcomes to show what worked, with the idea that any sort of plan, do, and study, act sort of circle. If people succeeded, they would adopt the process change. And if whatever they were doing did not work on a rapid cycle, monthly cycles, then they would get rid of it and they would actually create some process improvements. And then during phase 2, we started the reward system by setting a challenge, that is an expectation, and we would reward them if they actually achieved it. And it makes sense. People do respond to some of these things, although I will say that there are some laggards who, no matter what you do, are not going to change. And you'll get a chance to see this. I will say that we had a little bump where things dropped down in terms of the scale up because of the annexation of Crimea and ongoing conflict. And we put together a couple of challenges, and you can see that as we put in these challenges and use those things to change the law, you can see that the slope of the curve, that is the scale up, changes dramatically as part of this, because these are the sorts of things that work. Now, I won't present the final data on this, but just as a sort of a proof of concept, we've also been able to channel some of the interesting ways that it might actually benefit. One of the things that we did was because addiction treatment is relatively new in Ukraine, we created some learning collaboratives by travel to the US that is reflected in the yellow circles or the yellow donuts. In terms of like creating some expertise so that we could move people who were some of the early adopters and get some of the later adopters on board. And then I will say that there are 2 other things that are what we call disruptors. There were these privatized models of treatment that emerged in the country. And then COVID-19 really gave us a major disruption, which helped the work that we did. And I'll show you the data for how these kinds of things can impact it. So once again, we set the expectations, we support it with NIATEX, and then we reward it if they do well. So here are data in September of 2021. This is in the midst of the COVID epidemic. And as you can see, that all regions of the country are not the same. And recently, when we were looking at HIV coverage, it is very uneven across Peru as well. And there's a number of factors that sort of go into this. And so you see at least 3 regions that have exceeded 10%. You've got the majority of them, 13 of them, that are in this sort of middle coverage group. And then you have a couple of the places that just have not really succeeded. And then Crimea was annexed. There is no methadone whatsoever in that region of Ukraine. Now, one of the things that we have been especially focused on is really coming up with ways to reduce the treatment demands, both on patients, but also on providers. So one of the things that they often complain as a barrier is that they just don't have enough staff. So you could potentially say, well, can you give more staff? And, you know, if you speak to ministries of health, they are seldom willing to do that. But if you can create some efficiencies in what you're doing, you can actually improve it. So you want to do things that are really improve treatment access. There were some waiting lists. There were some admission criteria. And in some cases with these privatized clinics, there was a cost of treatment, but they also had incredibly high demands on patients. They were very inflexible. You had to show up from 9 o'clock in the morning to 11 o'clock, and that may interfere with your work. You oftentimes had to travel to specialty care clinics. There weren't enough of them, or there might have been some expenses, and shifting more towards removing those kinds of barriers, making them flexible, more hours of operation, sort of eliminating cost for patients with the idea that you get more or reducing the cost. So there's a number of things that basically happened as part of these change projects. They would, let's say, change the order in which a person had to go through the treatment system. So you can think about the test and treat strategy for HIV. It wasn't that many years ago when we used to sort of bring them in for one sort of thing to confirm their HIV, and then we would confirm it, and then we would bring them back and do the CD4 and the viral load, and we would coach them and do all of these things. And people were exhausted. It was too many demands. And some very clever people in Africa said, this isn't that hard, folks. Let's basically test and treat. Let's diagnose them. We can deal with the CD4 and the viral load later, and let's just give them the treatment. And lo and behold, you get 80 to 85% success rate, and you don't even need doctors to do that. So that's an example of lower demands. In places where patients have to travel, there are costs and there are time that go into that. So sort of removing some of those are examples of how you can actually have an impact with this. One of the things that happens as part of these practices as they start and they'll try something new, as you can see, is this was an example in one region of the country. What they did was they did a pilot testing of prescription. And we call these promising practices. They would give patients prescriptions, and then they would see what would happen, and they would all of a sudden enroll a lot more patients during that time period. They decided not to keep it at first, and they did it again, and it actually worked. So moving patients from take-home dosing actually allowed for less time, but it also got more patients on treatment in this particular region, where other places were not quite as successful. So the first one is the pilot buprenorphine prescription, and the second one is the pilot take-home dosing program. So these are what we call promising practices. And then because of Rogers'